conversation over to discussing stroke volume. Stroke volume is defined as the volume of blood ejected from the ventricle during one contraction. So if we look at our pressure volume loop or our Wigger's diagram, we can demonstrate stroke volume on these graphs. Stroke volume is the end diastolic volume, which is the amount of blood filling the ventricle at the end of relaxation, minus the end systolic volume, which is the amount of blood left in the ventricle after contraction. So on looking at our pressure volume loop, the end diastolic volume is going to be represented here at the end of ventricular filling, and it would be the same volume at the end of isovolumetric ventricular contraction. On our Wigger's diagram, the end diastolic volume is depicted at this point here. End systolic volume is the amount of blood in the ventricle after it is ejected. So this would be our end systolic volume, and this would be the same volume down here. And on our Wigger's diagram, the end systolic volume would be depicted by this volume here. So we can calculate the stroke volume by subtracting this number from that number, okay? Or subtracting our end systolic volume from our end diastolic volume. So let's look in to see what kind of things might affect stroke volume. So this slide takes us back to our discussion of skeletal muscle, and you'll recur with skeletal muscle, we talked about one of the things that can affect the force of contraction is the sarcomere length prior to stimulation. And what we said is that within our body, our skeletal muscles are arranged in such a manner that they typically are around their optimal length. And therefore, when we contract a skeletal muscle, we're typically getting somewhere around 100% maximum tension. Now, we're going to focus on just the very top part of this graph, this portion right here. So this next slide zooms into that point, and this again represents our skeletal muscle contraction, where for the most part we're going to be getting around maximum tension every time we stimulate a skeletal muscle. But the cardiac muscle curve looks different. The cardiac muscle curve looks like this. And so what this demonstrates to us is that around this optimal length in skeletal muscle, we're typically contracting at a very high degree of tension, but with cardiac muscle, we actually see a much greater range of tension that may be created. And this is a normal range of tension that may be created under normal physiologic circumstances. So what we're going to do is we're going to adjust this graph somewhat to make it more useful for us with regards to evaluating cardiac function. So what we're going to do is we're going to take the top part of this graph and we're going to stretch this out. We're also going to change the names of the X and Y axis. So on the Y axis, we say that represents maximum tension created, and that's really a reflection of the strength of contraction. But a more useful term clinically, correlating to the strength of contraction, would be the actual blood that's ejected with a contraction. So we're going to label our Y-axis stroke volume. The X-axis represents sarcomere length prior to stimulation, and the length of the sarcomeres in the heart is going to be dictated by the amount of blood that's returning to the heart. It's going to be the amount of blood that's in that ventricle prior to stimulation, and that is the end diastolic volume. So now we have axis labels that really are much more useful clinically. End diastolic volume and how it relates to stroke volume. So this is going to give us what's referred to as a cardiac function curve. So we've polished that curve up and demonstrate again our end diastolic volume and our stroke volume, and this is our cardiac function curve or length tension curve. So the amount of blood that fills the ventricle is going to determine where we are on this x-axis. So in this particular case, if we have the amount of blood return to the ventricle represented by these rather thin arrows, let's say that gives us a relatively low left ventricular end diastolic volume. And in this case, that would create a stroke volume of this magnitude. But if we increase the amount of blood that returned, that would give us a larger end diastolic volume, and this would give us a larger stroke volume. And we can continue to show the relationship between an increase in end-diastolic volume and stroke volume. This increase in stroke volume as a result of an end-diastolic volume, this relationship was given the name the Frank-Starling mechanism. So this is an intrinsic property of the heart, and what was found out was that in a healthy heart, whatever blood that we return to the heart, with the next heartbeat, that blood will be ejected. So we refer to this as shifting to the right along the cardiac function curve. So one of the theories behind why this works this way is that this stretched muscle appears to have caused troponin to have an increased affinity for calcium. And with that, we get more cross bridges exposed and therefore can create more tension. So this is how stroke volume may be affected by an intrinsic mechanism, and we call this the Frank-Starling mechanism. Now there's another way that we can also affect stroke volume, and this is going to be related to the sympathetic system and the myocardial contraction. This depicts a standard myocardial contraction representing over time how much tension a cardiac myocyte may create. So if we use this as our normal, then what we can show is what happens if we stimulate that ventricular muscle with sympathetic stimulation. And I'll refer you back to our previous picture where this shows sympathetics innervating both the SA and the AV node, but sympathetics also go and innervate the ventricular muscle. So it's this activity here that we're going to be depicting on this picture. So with sympathetic stimulation, we'll see that we not only do we create a more forceful contraction of the ventricular muscle, but it also happens more rapidly. So this increase in contraction brought about by sympathetic stimulation, we refer to this as an increase in contractility. So if all other factors remain constant, the more forceful contraction results in a greater stroke volume. Now if you recall, when we talked about the sympathetic and parasympathetic effects on the SA node, we called those chronotropic effects. So that's affecting the heart rate. Here, where we're talking about sympathetic stimulation of the ventricular muscle, we can refer to those as inotropic effects. And this is an extrinsic effect, so this is something outside the heart that's impacting the force of contraction. Now we can show this inotropic effect on our cardiac function curve. So recall that contractility, this positive inotropic effect, reflects the change in the force of contraction at the same end-diastolic volume. So if this was our end-diastolic volume, this would give us this degree of stroke volume due to Frank-Starling. But if we sympathetically stimulate that ventricular muscle, what this results in is, in essence, it causes the entire cardiac function curve to rotate upward. So at the same end-diastolic volume with sympathetic stimulation, we would actually be jumping up this cardiac function curve, and that results in a greater stroke volume. Now recall that our autonomic nervous system is on at all times with regards to its target tissue. So we may not only increase sympathetic stimulation, but we may also see situations where we can decrease sympathetic stimulation. And if we decrease the sympathetic stimulation, we would see this curve shifting downwards. So this would reflect a decrease in contractility. The receptors, once again, that are activated or that come into play with this inotropic effect are beta-1 receptors on the ventricular muscle. So let's try and put a few of these concepts together. Here is our starting end-diastolic volume, and this would reflect an increase in contractility by shifting up the curve. So this would be the effect of sympathetic stimulation of beta-1 receptors. So an increase in stroke volume as a result of sympathetic stimulation, and notice that we're depicting that at the same end-diastolic volume. This reflects an increase in end diastolic volume, and this is reflecting an increased stroke volume, and this is the Frank-Starling mechanism. So this change in stroke volume here reflects an increase in stroke volume due to the Frank-Starling mechanism. This increase in stroke volume represents an increase in stroke volume due to an increase in contractility. What we'll see as we continue to move through this section is that oftentimes we're going to see both of these effects at the same time. So we may see an increase in end diastolic volume and an increase in sympathetic stimulation. So we see the combined effects of an increase in stroke volume due to Frank-Starling combined with the increased effects due to increased sympathetic stimulation. Now we can demonstrate this increased contractility by a particular descriptive phrase or number. Let's look at some volumes here. Let's say we start out with an end diastolic volume of 145 milliliters and an end systolic volume of 65 milliliters. This would give us a calculated stroke volume of 80 milliliters. If we increase contractility, if we have this positive inotropic effect by sympathetic stimulation, what we're going to see is we still start off at the same end diastolic volume. Remember, that's how we discuss contractility, is the effect at the same end diastolic volume. So when we stimulate this ventricle beta-1 receptors, that causes a more forceful contraction, and that's going to eject more blood from the ventricle. So we're going to have a lower end systolic volume, and this would give us a stroke volume of 90 milliliters compared to our normal of 80. Well, the way that we can depict this is with a number called the ejection fraction. So the ejection fraction is a measure of contractility. And the way this is calculated is we calculate the ejection fraction by taking the stroke volume and dividing it by the end diastolic volume. So in this particular case, stroke volume divided by end diastolic volume would give us an ejection fraction of 55%. In this case, where we have sympathetic stimulation, it would be stroke volume 90 divided by 145, and that would give us an ejection fraction of 62%. So what we're depicting here is an increased ejection fraction, which reflects an increase in contractility, which is due to sympathetic stimulation or a positive inotropic effect. Now, we've mentioned here that a normal ejection fraction is around 55%, and so these numbers reflect a potential change with that. So in summary, stroke volume is the amount of blood ejected with a single contraction. We can modulate or we can adjust stroke volume by two main mechanisms. One is by sympathetic stimulation by beta-1 receptors. This would be our positive inotropic effect. That results in an increase in contractility or an increased ejection fraction. The second mechanism is by changing the end diastolic volume, and this is our Frank-Starling mechanism.